someone who's now in a workout class in their 50s, or not even that, maybe they've stopped exercising for 5 years because of the fear of leaking, because they can't do any of the exercise that they want to without leaking, and so they've moved away from exercise altogether. If those women had been educated younger, through potentially their pregnancies, actually been offered proper postpartum recovery and rehabilitation, might not be in that scenario now. Pelvic health is way beyond just our pelvic floor and our postpartum recovery. It really encompasses our entire pelvic health, digestive system, and pelvic organs, reproductive system, menstrual system, hormonal system, all of that together.
Hello, welcome back to the Health Review podcast. I'm your host, Emily Rose Adams. Now, today we're diving into a topic that deserves far more attention: pelvic health. And joining me on this is Jenny Fielding, a specialist pelvic health physiotherapist at Mint Wellbeing in London. With over 15 years of clinical experience, Jenny's dedicated the last decade to managing female health across all life stages. She's also an advocate for women's health education, speaking at international events, schools, and corporations. In this episode, we discuss practical strategies to enhance pelvic floor function, address issues like incontinence, prolapse, sexual pain, erectile dysfunction, and post-vaginal birth recovery. No topic is off limits today. Also, as a mother of 3 who's personally navigated prolapse and postnatal anxiety, Jenny brings both professional expertise and personal insight into the physical and emotional aspects of pelvic health. She does an exceptional job of breaking down complex subjects, and this conversation offers invaluable insights for everyone.
Jenny, thank you so much for coming on to talk about your important work that you're doing. You specialise in pelvic physiotherapy. For those who don't know sort of what that might involve, what is pelvic physio, and who are the types of people who could benefit from it?
Well, firstly, thank you for having me. It's very nice to be here and share more about this, slightly underknown area. In my echo chamber, everybody knows about pelvic health and what it obviously entails, but in the general population, like you say, it's probably a little bit less well known. I think people might be more familiar with the term women's health physiotherapy, and over the last few years that's really transitioned into being more of pelvic health, mainly because we treat all different individuals and different genders, but also because the pelvis encompasses lots of things that aren't just female specific, and so I guess in terms of commonly things that we might it's mainly sort of around the pelvic area and pelvic floor. So issues around bladder complaints, bowel complaints, sexual dysfunction, heaviness, prolapse type symptoms, erectile dysfunction in men, and as well as sort of pelvic pain, and all that encompasses. And pelvic health physiotherapists will often also specialise in certain periods of time in a male or female's life. So particularly in female life cycles, we obviously know we transition through various different stages. So pelvic health physios might be involved in kind of menstrual conditions, in pregnancy, in postpartum, in perimenopause, postmenopause, would be when we commonly see, I guess, changes in our pelvic health.
And I guess a lot of us, when we think of pelvic health, I don't think there is much knowledge out there, but if you ask sort of any member of the public, they might think, oh, that's probably for women who, post-pregnancy, they've given birth, they might have issues.
Yeah.
I remember the first time I ever really heard about this was years ago when Holly Willoughby was on national TV, British TV, on This Morning with her co-host Philip, and they used to laugh so much. And she's had multiple children, and I remember she used to have to crouch on the floor because she thought she was going to wet herself on national TV, which obviously would be hugely embarrassing. And then I remember it started a bit of a conversation around, that does happen to women. But you mentioned many other things there, which I think a lot of people just wouldn't even realize is actually quite a common issue. So problems with your bladder, sexual dysfunction.
Yeah.
These things are quite sort of taboo topics. Do you think that's still an issue at the moment for kind of the narrative around maybe going to see someone like yourself for help?
Yeah, I think definitely. I think even friends of mine who know what I do, or clients who I've seen at one phase in their life are like, oh, did you help with that as well? So I think there is, even when you think that your your education and your ability to get the message out there is good, there still is a lot of confusion about what we do. And I think also physiotherapy as a general sort of career and general sort of profession, people, even clients who come to see me for a pelvic health appointment, are often quite surprised that involves maybe assessing their pelvic floor, or might involve assessing their pelvic floor, and obviously that often involves a vaginal exam or an anorectal exam. And I think there's still lots of misinformation around what all of that involves, and why physiotherapists might be involved in that area of the body. So yeah, I think there's also that notion that this is really just a female problem, and it's really just a problem that happens in pregnancy and postpartum. There's also an acceptance element, I've had children, of course I leak on the trampoline, or those kinds of things, which I think, again, historically, maybe in the way society was set up, women accepted those things more. And I also think women are getting back to a much higher level of activity and exercise postpartum now. So perhaps they have more of a demand on their physical recovery, and are much more aware. I have a lot more clients who advocate for their health and are aware of prevention, of early intervention, of knowing that things they shouldn't have to live with or accept. But again, that's very much in my, polarized echo chamber of what I see. And outside of that, I'm sure there's lots of people that wouldn't even know, common things people will say, like, oh, I've just got a small bladder. Like very
Something
rarely,
I would say.
Exactly. Yeah, very rarely do we actually have, a physiologically small bladder. We probably have got some, poor bladder training and some poor associations with our bladder behaviour and our bladder health, and a lack of information. And, really and truly, this stuff should be taught in school. Should start at home if parents are aware, even in the way we potty train children. We always are saying to the kids, oh, we're going out now, you need to go, I don't need the toilet. Well, just go in case.
Yeah.
And so from a very young age, we're almost encouraging some of these relationships with our toileting behaviour. We also stigmatise going for a poo, and going to open your bowels can be quite a negative thing. And, even the way school toilets are set up, they've got a big gap at the bottom, big gap at the top, they're not very soundproof. So, then we create these negative associations with our bladder and bowel behaviour from a really young age, and that's often things that I will see in adults, both men and women, and when you track it back, it's actually nothing to do with maybe a pregnancy journey or a postpartum journey, although of course they are big risk factors, but it's just based on poor health education, and a lack of awareness and a lack of education, and just generally, I guess, an uncomfortable taboo-ness around something that ultimately is completely normal and completely healthy for all of us. So it's the same with sex education. I think there's menstrual education's another one. We still hear of girls who come on their period at school for the first time and have absolutely no knowledge that is going to happen, or what that's all about. I worked in Hong Kong for a long time, and I would, I remember doing lots and lots of educational work in schools and conferences, and going to speak at events, and I would have girls ask me, I've heard about a stick that I can use for swimming when I have my period, and obviously talking about a tampon, just a lack of awareness. They're finding that information out on the internet, or through hearsay, but not always necessarily high quality information, and then they don't really maybe have a trusted resource to go and corroborate that information, or really have piece it all together. So I think I've rambled on a bit there, but thinking about it, pelvic health is way beyond just our pelvic floor and our postpartum recovery. It really encompasses our entire pelvic health, digestive system, and pelvic organs, reproductive system, menstrual system, hormonal system, all of that together. And I think that's why a lot of physiotherapists who work on chronic pain and complex conditions sort of end up migrating towards including pelvic health a lot more, because ultimately the body is all connected. So my chronic back pain could have a menstrual component and have a cyclical element, and we sort of, as we get more knowledgeable, can see the interaction in all of those things, even our gut health.
That's so interesting that your gut health could affect that area.
Exactly. You know, I mean, if you think about constipation, you know, one of the biggest risk factors for something like a pelvic organ prolapse is constipation and chronic straining, or a chronic cough. And so, you know, if we've got really poor gut health, we've got really poor relationship with food, maybe we've got poor, you know, ability to get good gut motility and transit, our gut bacteria is not very happy, you know, we're much more likely to not have a very healthy relationship with defecation, so with emptying our bowels. We might be doing lots of chronic straining, and that could be really negatively affecting your pelvic floor. So it's sort of all full circle, you know, and I think one of the exciting things about it is that, you know, actually a lot of these things can be changed with really simple things, rather than it being a very niche, complex activity or exercise you have to do, or a crazy supplement or whatever. Most of the time, if we can just do basic bladder and bowel behavior, you know, and reasonably good nutrition, focus on our hydration, our sleep, the way that we go to the toilet, you know, very normal day-to-day tasks, we can have a really positive effect on all those kinds of symptoms if they are something you're struggling with.
And I'm guessing for you it's quite a rewarding sort of job. You know, you're seeing these people who are probably quite desperate at points. You hear of women who, I guess, maybe post childbirth or even years later, an exercise class, you know, having an accident, wetting themselves, and like, these experiences must be so deeply traumatic that they come to you like desperate for help. And I guess you get to coach them through this process and hopefully help them to a point where that sort of incident either happens less frequently or stops happening. How did you get into this speciality within physio? I'm keen to know.
Well, I started off, you know, in generic physiotherapy, and actually I used to work in the hospitals in paediatric intensive care, and I absolutely loved it. We did, you know, on-calls and things like that, and we helped babies with their respiratory system. And I think I just got to a point where I felt like I always wanted a little bit more in that environment, and really that the next step would be to retrain as a doctor. And at that time, the age I was, I felt like 5 years was a huge amount of time, which looking back, it was, you know, nothing. But that wasn't really at the time the thing I wanted to do. And so I moved into sort of musculoskeletal physiotherapy, where I feel like we maybe have that real niche in our input. And then I moved out of the NHS and did various things and a few ski seasons as a physio and things like that. And then I just by accident fell into working for Matthew Bourne's Swan Lake, so working for, you know, a ballet company with a sort of ballet and contemporary dance. And I worked for those who don't know, his Swan Lake production is all male swans, but they have obviously females in the cast as well. And it was just really exposing, I think, to me to see the differences in female and male athletes or performers, and see how there were those female specific, you know, factors that could influence the female dancers and their recovery, the different things they had risk factors for. So, you know, stress fractures, you know, relative energy deficiency in relation to their menstrual cycle, sort of not having enough fuel for the demand of their activity, and also the sort of misconceptions around, you know, not eating certain things, not doing certain weight training. So women weren't being given the same opportunities to be able to prevent those injuries and risks as well. And just a huge lack of education and information. And again, in that space, there's a lot of pelvic health conditions and in very much not postpartum because it's very repetitive, high impact, lots of jumping, often on very, very firm floors. You know, obviously it's changed a bit now, but many of the theatres we would travel to would have a very hard floor. So lots of things that are going to put a lot of stress on that area. And I just really found an interest in the female athletes. And then I started attracting more female clients who obviously then often are pregnant postpartum. And so I kind of found a bit of a calling, and probably honestly between you and I, you know, well, and everyone listening, but I started to find it less rewarding if someone had sprained their ankle, you know, whether I could get them better in 2 weeks or 4 weeks. And I found this whole area around these topics just so fascinating, and like I could have such a big effect on someone's quality of life. So then I really transitioned all into kind of women's health, particularly pregnancy and postpartum, because it's, I guess, where we're a little more well known initially, and then from there have just, you know, become, done more and more of this sort of bowel, bladder work, sexual pain, and see men as well for men's health conditions. And I think just having that safe space where someone can talk about those things, and a lot of the time the education that we offer is already improves someone's symptoms and their outlook on their symptoms so dramatically. And that is really rewarding. It's also quite sad sometimes that people have had to get to that point where they're suffering so much before they're accessing help.
What would be an example of that, for instance? So if
I guess like you were saying, someone who's now in a workout class in their 50s, or not even that, maybe they've stopped exercising for 5 years because of the fear of leaking, because they can't do any of the exercise that they want to without leaking, and so they've moved away from exercise altogether. And for some reason, somehow they've come and ended up in my clinic. And again, if those women had been educated younger, through potentially their pregnancies, actually been offered proper postpartum recovery and rehabilitation, might not be in that scenario now. And likewise, as our knowledge of perimenopause and menopause evolves and we recognise the hormonal changes, again, educating women there around what that means, what things like vaginal estrogen can do to help. I hope that by the time my daughter is that age, she's a lot more informed, and that she's accessing support from people like me preventatively, rather than, at the end of a road that has really pulled someone out of exercise altogether.
So you've sort of touched upon some of the risk factors there.
Yeah.
What are some other risk factors? So say, I've heard, these could be myths, maybe you could debunk them for me, but if you perhaps have a weaker bladder, is that something that can affect, later down the line? So say you drink coffee and you get an irritated bladder, does that mean then if you have children you're more likely to have like issues in this area?
No, not necessarily. So I think the term weak bladder, or people say to me, I've just got a really small bladder, I have to go all the time. So that would be what we describe as urinary frequency. So urinary frequency is a symptom. That isn't, you're not generally born with urinary frequency. It would be normal to go to the toilet sort of 6 to 8, maybe up to 10 times in a 24-hour period, and only really 0 or 1 times overnight. So if that isn't you, and you feel like you are going every hour, then that would be something that often very simple things can change. It might be that your fluid intake is really high, and you're worrying so much about getting your 2 litres of water, but you're also having 4 coffees and a smoothie and a soup, and you're just overloading the bladder, and it's therefore constantly needing to exit that excess fluid and process that excess fluid. It could be that you are more sensitive, and so your bladder has become a little bit like the Pavlov's dogs concept. If we've constantly associated a certain sensation as needing to empty our bladder, that becomes the normal, and our brain has attributed that to being, my bladder must be full, when maybe it's only got 100 millilitres in. It could also be that you have learnt these associations, so turning on a tap is a classic one, putting your key in the front door, things that where we've normally done that thing and then immediately passed urine, we can sort of create that relationship where we've almost trained the bladder and the brain relationship.
Wow, that's so fascinating. Like, you'd never think that these subconscious things that you're doing could lead to you going to the toilet more often. It's so fascinating. I know that quite a common thing that I've heard and I've definitely experienced is the anxious we of because I've worked in broadcasting, so every time before I went live, because I would do news sort of on the hour or every half an hour, I think, I better go just in case I get stuck in the studio. So I would find that I was just going to the toilet just for no reason. Is that a problem? Are you causing yourself problems by doing that?
I mean, ultimately, with all of these things, I always say to a client, is it bothersome to you? Is it bothering you? Is it something you'd like to change? Because sometimes the act of changing it, is a bit of a process. You're going to have to retrain that relationship. So it doesn't necessarily mean you're definitely going to have onward problems. Although we probably do see a correlation between those higher frequency bladders that then you can become, maybe you're needing to then notice you're going at night time a bit more frequently, and then maybe you're also starting to get some urgency, whereby then if you don't go on that regularity that you're used to, you then feel very, very desperate, and obviously that's then going to be a little bit more problematic. And so, I guess the key things is kind of education, but the just in case we're all guilty of it if we potty trained our children. I still do it to my kids sometimes. Do you need the toilet? No. Are you sure? Do you want to go just in case because we're doing a car journey or whatever? I think a just in case wee once a day is quite typical, like coming into this room today, if I know I've had a coffee on the way here and I'm going to sit with you for an hour and I'm sort of a little bit needing the toilet, it would be quite typical to have a just in case, go and empty my bladder when I'm aware it's not fully, really full, but also we're not wanting to be distracted sitting here talking to you. But, if in your case you're then doing that every hour, ideally we can go sort of 2.5 hours with a normal fluid intake. So that might be something you wanted to look to see if you could stretch a little bit. But there are lots of different reasons. So in clinic, something we would do is ask a client to fill in a bladder diary. So they would fill in, what they were drinking, how often, what time, and actually, measure the fluid output. So how much they're urinating into a little measuring jug and then pour it in the toilet, write it down. And then from that, we can analyse really what is driving the behaviour, because then there are probably 4 different types of reasons why you get the frequency. And then there are multiple reasons why the urgency would occur. Some people will be urgent but not leak. Some people are urgent and do leak. Some people have that associated with a discomfort or an awareness that's uncomfortable. And then based on all of that would help us really target what we were going to do, because, almost some of the treatment modalities contradict one another slightly because they would be trying to target different things. And for some women, they might have that notion already, and then they additionally get a weaker pelvic floor, and they also get some stress incontinence, which might be, a jump or leak or cough, jump or skip or cough and leak a little bit. And so then they notice their urinary frequency gets worse because they're going even more now because they're worrying they're going to leak. So in that scenario, we'd really want to treat the stress incontinence mechanism and then work on the frequency. So, I think that all sounds very complicated, but ultimately what we're trying to do is restore the bladder's normal function. Simple tips would be, don't drink your drink really quickly. Your bladder's a muscle, so when it feels that stretch very quickly, the receptors on the bladder lining will send a message to your brain saying, oh, the bladder's filling up really quickly, you must empty. So that can sometimes be a trigger. Some people are sensitive to caffeine and alcohol and sugars, some aren't. So, you definitely don't have to cut those things out if they're not triggering you and they're not sensitive. For some people, it's those associations like the key in the front door. So we sometimes talk about, even pop the key in the door and then just stop. Take a few deep breaths, even go up and down on your tiptoes. We've got a little bit of nerve in our calf and ankle area that also exits from the same part of our back that goes into our bladder, so we can sort of trick the bladder slightly to not feel that sensation. And all these little things, tips and tricks, and then mean you can calmly go to the toilet without that rush, the rushing run that we see people doing. But yeah, that all of that is, if we could talk about that in school, women would be able to go, oh, okay, well, I know I've had 2 cups of coffee and a water, and I know my bladder's only X big, so of course I need the toilet, and then that'd be kind of like rational versus, well, I haven't drunk anything for 3 hours and I just went an hour ago, so I probably don't need to go. And it's something that I'm, just is a habit that I've got into.
Sorry to interrupt. If you're enjoying today's episode, please do subscribe or give it a follow so we can keep giving you excellent content and bringing on amazing guests that hopefully you're loving on the Health Review podcast. Now, back to the show. What is it about pregnancy that sort of leaves people with this weakness after, and is a natural birth more likely to lead you to have problems in the pelvic floor region than if you have a C-section?
So, with pregnancy, there's the obvious of, there is a growing human inside your uterus, and your uterus is one of your pelvic organs, and your pelvic organs are in part supported by your pelvic floor muscles. So as that gets much heavier, we often think of like a watermelon on a piece of cling film, naturally there's going to be more demand on that muscular sort of hammock. And it's also in part that many women haven't really thought about training that area of their body until that point. It's maybe not an area of their body they're aware of. They might have some bad habits like straining when they're, lifting weights, or straining when they're emptying their bowels and things like that. And so it's just about bringing some awareness to that area. And also hormonally, our body is designed to have a vaginal delivery. Obviously that isn't the case for many women, either through choice or other, but ultimately that's physiologically what our body is intending. And so our hormonal change will allow some more elasticity in our pelvic floor muscles. They have the capacity in birth to stretch up to 300% of their length, so very different to say my hamstring muscle, which probably couldn't stretch that much. And so all of that is certainly a risk factor. We also note that women get a bit more constipated often in pregnancy, because one of the hormones, progesterone, slightly slows down our gut transit, so it's trying its best to give all the good stuff to baby, so it steals everything, and that means it's a little bit of a slower transit. And then some of the supplements women might take, like an iron supplement, will also contribute to that. So again, constipation is a risk factor. So it's sort of all of these different things. In terms of birth, both C-sections and vaginal deliveries have, for different reasons, women can note pelvic floor symptoms postpartum. It could be related to the pregnancy changes, and obviously with a vaginal birth, it makes sense that you've had a big stretch to those muscles. Often you've had a tear, you might have had a cut with an episiotomy, you may have stitches, you're naturally going to have some swelling, and all of that's going to take those muscles some time to recover, and they're going to, like anything, if I had a big sprain in my ankle, I would go through a rehabilitative process, but we sort of just don't think about that with the pelvic floor. I think sometimes postpartum we just think, oh well, everyone does it and off I go back to the gym, because there's this notion about snapping back and body image and bounce back, all of that kind of thing. But with a C-section, it's not uncommon also for women to notice pelvic floor changes. That could be because they've got a lot of discomfort abdominally and they're sort of holding a lot of tension in their pelvic floor. They might notice discomfort with intimacy. They might also notice changes in urinary leaking or constipation, things that are maybe a little bit more associated with a more active pelvic floor. And likewise, they may also, just from the pregnancy, have some changes to their pelvic floor strength. So tight doesn't always mean strong. We kind of want a strong and a long pelvic floor, like my bicep can, do that motion. So, we see a whole spectrum, and ultimately in an ideal world, everyone should know about their pelvic floor. If they just went once and, 1 in 3 women are doing the wrong thing, or probably 1 in 5, I don't know, depending on what you read. But, so first of all, learn what it is and how to do it. And then you might go again in pregnancy to see how it's changed. And then postpartum, all women should be offered, the option. And unfortunately, the NHS isn't in a position to provide that for everybody. So women have to seek that out privately. And there's a challenge, obviously, with people being able to afford that ultimately. And then, later on in life, as we transition again, it's sort of like regular check-ins, I think, is helpful.
So if someone were to come and see you with some of these risk factors, potential symptoms, you speak about talking to women about what they can do rather than what they can't do.
Yeah.
What would be your sort of first consultation? What kind of assessment would you make with your client?
So a lot of history taking at the beginning, because as we've discussed, these things can track right back to childhood. Obviously, it's relevant if they've what their menstrual cycle has been like, if they have any menstrual conditions, their pregnancy journey, their birth journey, what level of exercise they've managed to continue with, whether they used to be a high-level gymnast. All of these factors are going to be really relevant. And then we would, the pelvic floor is obviously really important, and we definitely include a pelvic floor assessment, assuming clients consent to that. But we also want to look at the whole system. If my rib cage is really restricted and I don't have much rotation and I'm really gripping with my upper abdominals all the time, then the pressure that's creating down on my pelvic floor is going to impact my pelvic floor function. Even the way I breathe, my diaphragm is a muscle that's moving up and down, and my pelvic floor should move in sync with that. And lots of us are breathing very apically, and there's a lot of focus now on breath work, which is amazing. So even looking at someone's breathing pattern, looking at their posture, the position of their pelvis, their general strength and stability. If I'm very weak in my legs and my calves and pushing up on my tiptoes, then when I run, I'm going to put a lot more force through my pelvic floor. So it's sort of looking at all of those things and trying to think, sort of system-wise, what might be affecting this, and why is someone having the symptom that they're having. Obviously, if it's a bladder, like the just-in-case wheeze and the frequency, then it might be more looking at their nutrition, their fluid intake, actually the bladder diary analysis and things like that. So it's going to be very dependent on the condition. And then, we would often include a vaginal examination, assuming the client wanted to do that. We'd explain what that process entails. And really that's trying to give us information about, is there any sensory issues? Are there any skin issues that haven't been picked up? Any lumps and bumps and things like that might warrant a different referral. And then are they able to engage the pelvic floor? Can you see externally? Has it got reasonable symmetry? Have they got a good amount of muscle bulk? It'll just like I'd assess someone's arm or their elbow. And then looking at whether or not there's any indication of prolapse. We would assess the pelvic floor sometimes standing up. So, if you came to me and said, well, actually, I only leak after I've done 6K run, and then it's really just a real problem. I only leak when I do double unders in CrossFit. Then lying down, assessing your pelvic floor might give us lots of information, but it might not give us enough because your symptomatic profile is not when you're lying down. So we would then try and replicate as best we can those scenarios. Sometimes clients would come in at the end of the day after their 10K run, and we would assess them then and try and understand what's different. Is there a fatigue component? Is there something else going on? So we use ultrasound as well. Sometimes clients wouldn't be comfortable with a vaginal exam, which is totally fine. So we might assess them abdominally with the ultrasound or transperineally, so placing the probe at the entrance. And you can see on the screen then, lots of funny grey and white lines, but you can then sort of learn which ones are which, and we can teach the client to see the pelvic floor moving, pelvic floor relaxing, or the bladder lifting and the bladder lowering. Because it is a very alien area of the body, and it's hard to maybe understand what it all means sometimes without that feedback. So it would really take its own path depending on their level, what they're there for, where in their journey they are.
I think it's one of those things that, as you say, so many people don't even think about it, potentially women until they're pregnant, and suddenly they're going to these classes where they're being taught breathing and told, oh, you use your muscles, your pelvic floor muscles. I trained in ballet. I went to a ballet school, and I remember from a very young age they would teach us that you have to imagine that you're doing up a sort of zip, almost like your jeans zip. And we were sort of taught to pull in as much as possible and to practice that. And one teacher would say, oh, pretend you're going to the toilet for a wee and then stop and then just hold it and do that again. And we did this a lot, but I felt almost that for me, perhaps and many others, we were sort of a bit overactive in that area. Can that cause issues too? If you're, say, like clenching a lot, I guess it comes back to tension perhaps. So I think a lot of women think, and men, suck it in. Guys at the gym when they're lifting heavy weights, they'll kind of suck in their stomach or tighten their glutes. Can that sort of tension lead to other issues?
Definitely. And I think the pelvic floor, I describe it a bit like a dimmer switch. If I'm doing something really high demand, I would need my pelvic floor probably to be on quite a lot. If I'm doing something low demand, like now talking to you, I'm sitting, I'm supported, my belly's relaxed other than the video watching me, but, then I am much less likely to be holding tension, and my dimmer switch might be right down at 5%. So I think it's when we mess around with that too much, so when we now are thinking about holding my pelvic floor in whilst I'm sitting still, and ultimately I don't need to, but now if I was standing up and maybe projecting my voice a bit more, my pelvic floor should ideally reflexively turn on a little bit more. Or if I was then going to run, it might be on, I don't know, let's argue 50%, but I trip down the curb, I would expect it to turn up a bit, to support that, and then maybe go down again. Or I coughed, I would expect it to turn on a little bit to support that bladder and then relax again. So, ideally it's a very clever muscle group that sort of does its own thing, and we don't necessarily need to interfere too much. But I think then when we're constantly being told to clench and squeeze, and especially when we're probably not clenching and squeezing our pelvic floor either, we're squeezing our bottom, or we're holding our inner thighs, we're doing something else, we're kind of messing with its flow a bit. And then we do see quite commonly in ballet dancers and Pilates instructors and things like this sort of overactive or more active pelvic floor, which then can contribute to a pelvic floor that doesn't know how to relax, which then might affect your ability to empty your bowel or empty your bladder fully. So maybe we're going to the toilet all the time because we don't actually relax and fully empty. We half empty, and then we need to go back again, of course, because we're not empty. You might notice discomfort with intimacy, or can't tolerate certain positions in intimacy, difficulty wearing a tampon. So definitely, but equally there's we discussed earlier, the pros and the cons of information on places like in social media. But there's also a big focus now on this hypertonic or overactive pelvic floor. And again, maybe a little bit too far the other way. Really a muscle like my bicep should be able to squeeze on to its max capacity and relax all the way down and really respond when I need it. And I think sometimes it's that we've got involved with something. I think we'd be better off looking at bladder and bowel education in that younger population than necessarily lots of pelvic floor squeezing, particularly because it would probably not be appropriate to do a vaginal exam in a young group. And we know from the data that, at least 1 in 3 women are doing the wrong thing. So then we're teaching someone verbally, knowing that 25% or a third of that population are doing the wrong thing, and then encouraging them to keep doing the wrong thing all the time. So I think we'd be better off focusing maybe on the bladder and bowel education at that point.
And if someone's coming to you for treatment, what might some of those exercises look like? So you've mentioned the hammock, so a big muscle that goes from one side to the other. What sort of exercises might someone learn from you about sort of controlling it better or preventing leakage, or if they're having prolapse? I guess they're all slightly different exercises for different problems.
Exactly, yeah. And so, the traditional sort of Kegel exercise that, we might hear is really just a name from the person that first appreciated that this was a group of muscles we had conscious control over. So it was actually a surname, but really just means engage your pelvic floor muscles. So I think a lot of the time, like you say, it's a little bit different depending on the problem, but the primary focus is going to be teaching someone to be able to fully engage all of those muscles and then know how to fully relax all of those muscles. And depending on their dysfunction and also when that occurs, depends on how relevant that is, So it might be that someone's pelvic floor is really good and actually really strong and it's great, but the reason they leak in CrossFit when they're doing double under is actually because they're holding their breath, they're sticking their chest out, they're not putting their pelvic floor in an optimal position, and so they're not able to recruit, or they don't have the speed and coordination to recruit in that double under sort of forceful activity, but with a normal pelvic floor contraction they're fine. So for that person, it's going to be much more about an integrated training approach, trying to teach them how to utilize the pelvic floor in a functional movement, and just trying to work on that coordination, maybe that speed, depending on what it is that's the problem. Somebody who's got a prolapse, we might need to focus a bit more on some, lying down pelvic floor exercises, really trying to get that pelvic floor muscle lifting and supporting when the pelvic organs aren't leaning on it.
So with prolapse, it's quite a scary word, isn't it?
Definitely,
is that when things just sort of move south? Gravity pulls it all down.
It's such a horrible word, and I think that is honestly part of the problem. In my personal opinion, I think particularly in the early postpartum population, it's not really something we should use at all. I often will just talk to clients about laxity, so if you imagine your vagina as like a sock, and it was a very small sock, and then a human being came through and it stretched that sock a little bit, or like if you blow up a balloon and then you deflate it, it looks a little bit different, and that's very normal in those early few weeks and months postpartum. And so in that time you might notice that it's a bit more prominence of your bowel leaning forward on the back wall of your vagina, or you might notice a bit more prominence of your bladder leaning a bit on the front wall of your vagina, or your uterus might be a little bit lower down in the vaginal canal because obviously it came down and helped you deliver a baby, and all of that is sort of quite a typical postpartum change that then with some restorative rehab and time ultimately and good nutrition and all of those other things often gets to the point where it's not a concern and someone's not symptomatic.
How would you know you have prolapse? So is it something you can feel, or is it?
Yeah, often people would describe a sort of heaviness or dragging sensation. People might describe like a tampon kind of falling out feeling when there isn't obviously a tampon there. Women might describe incomplete emptying of their bladder. So they go to the toilet, but only a little bit comes out, but they know they're full.
Right.
So the bladder sort of maybe kinked down a little bit, or inability to empty the bowel properly. So feeling like you're trying to empty but it's not coming out, and maybe the stool is kind of sitting in that sort of prolapse area, or kind of a heaviness sensation. We do see it obviously a lot more, and as women get older we see it, there's more prevalence.
Why is that? So sort of post-menopause, is it a hormonal change that affects that area?
Yeah, and I think my hope is that with more knowledge and education, we maybe see it less in that population because they are given access to good pelvic health education younger, and then proper postpartum rehabilitation, and then maybe we're not seeing that quite so much. But it's a combination probably of poor habits, pelvic health habits through life, maybe a traumatic vaginal delivery or poor postpartum recovery, weaker pelvic floor, maybe a muscle tear like an avulsion that never really got fully recovered, and then ongoing multiple years of not maybe optimally looking after that area of our body. And then we often see things change a bit more when we hit perimenopause and menopause. Estrogen is often lower then, or certainly fluctuating in perimenopause, and estrogen is really a very helpful hormone. Might describe it as the water to your garden. You sort of need it for all the cells in our body, but it also has the capacity to keep the tissue vascularized, so nice capillary fill, good sort of buffer. So now when my pelvic floor lifts, it's actually there's something there. It's going to give some support to my my bladder or my pelvic organs, and also has a role in actually maintaining muscle bulk and muscle health, as well as lots of other things, lubricant to the vaginal tissues, things like that. And often when that reduces, women have maybe been coping and then, or not noticing, and then that little bit of change is enough to make their symptoms more prominent. Hopefully it's a word that we stop using and they think of a nicer word, but it also isn't the end of the world. After my first vaginal delivery, I had a prolapse bladder. My bladder was leaning a bit on the front wall of my vagina. I felt quite a lot of those heavy symptoms. I did this job, but I still found it mortifying. And I aesthetically recovered really well from my pregnancy. So I got lots of, oh, you look amazing, you're doing great. And inside, I just felt super mortified, embarrassed, had lots of postnatal anxiety. And none of that was really recognised. It was all about my aesthetic recovery. And, I think that really highlighted, but equally, through time, rehabilitation, I wear a pessaries, like a little support that just for netball, don't need to use it for running. It's like a sports bra for your pelvic floor, I describe it as. It's now just not something that causes me any concern at all. And is just really a little bit of a normal part of having a vaginal birth, a little bit more stretch in certain areas of the pelvic floor muscles. But I think often it conjures up these horrible images of the whole thing falling out, you know, and of course that does also happen. We can have quite substantial prolapses, and women do require surgery sometimes. But there are lots of things that, you can do, and you can still stay very active if you have one. And, I think more and more physios are really good at treating that. And fit these pessaries, which, is a little bit like, just sort of like a menstrual cup but different shape, that just gives a little bit of support in the area. And some research is even showing us that combined with some pelvic rehab can reverse the stage of certain prolapse as well. So it's not like a death sentence, like it's sort of maybe been created or thought of before.
And if you're having issues in this area, maybe post children, maybe through the menopause, is there any kind of long term, is the goal to kind of get you back to like where you were pre-children, or is that kind of out of the question and it's more like seeing an improvement and then learning how to manage and perhaps exercises you can do and can't do? Or is the goal to be like, right, you can do everything, let's come up with a long-term plan? I
think it really depends on so many factors. If you've had a very significant birth injury, you may have some long-standing changes, and it may not be realistic to exactly get back to how we were pre-children. And I think, just like that balloon analogy, our abdominal wall stretches to, house a human being, and it naturally won't for everyone. Of course it will for some, but it won't always recoil straight back to exactly how it was before. We get wrinkles on our face, we get grey hairs, things do change in the body. And I think it's also about recognizing what is just a normal sort of slight change in our general sort of physiology and function, and what is something that can be improved. And I think ultimately it depends on how much it bothers you and your quality of life and what you want to do. Because women, if they want to run should be able to, you know, if they want to lift weight, should be able to. And nearly always there's something that we can do to get you there. It might be that one person just needs a bit of information and education. It might be someone else needs a really thorough, you know, 4 to 6 month rehab journey, plus or minus a pessary, plus or minus some kind of supportive underwear to get them there. It might be someone else requires surgery, you know, but I think there are lots of options. And it's about getting, you know, rather than thinking about getting our body back to that body it was before, it's thinking about getting us to the functional task we want to be able to do. You know, have pain-free sex, go to the toilet without straining, be able to run that 5k without leaking, be able to pick up my grandchildren without fear of prolapse, you know, whatever the thing is. It's about, we should all be able to support people most of the time to get there. Whether that's just with physiotherapy or whether they need help beyond that, you know, will be really variable as to what it is that's led to them getting there. You know, HRT is another thing that helps a lot with, you know, in that menopausal phase. So yeah, I think it's viewing everything like that rather than this, can we get back? You know, it's like we're not trying to bounce back to who we were before because we're no longer that person for lots of many great reasons. So it's more about how can we move forward with ourselves, understand our body, understand, you know, the demands of it, and optimize our fitness and our strength and our health as best we can to do the things that make us tick, you know, and make us feel passionate and give us, you know, the reward that we're looking for, and keep our physical and mental well-being at the top of the priority.
And you hear of really sad situations, particularly with women who, after children, you know, they can't be intimate with their partner because they have pains or prolapse or things going on where it just doesn't feel right, doesn't feel the same, they're scared and can't exercise in the same way they used to, so potentially see a change in their body. They can't shift the weight that they've put on and therefore have low self-esteem, can lead to depression. Like I guess this area is actually hugely important for men and women, but particularly women who go through childbirth and have had this change, and it could almost sort of shape the rest of your life. You know, if you really find a way to perhaps improve it if you're having issues, it just seems like, you know, talking to you about it, it seems like obviously it's such an important thing that we should be speaking about more, and hopefully the taboo will kind of shift in time, and more people like you speaking on podcasts, and it kind of makes you realize that actually this is quite common, it's normal, and we should 100%. All just be comfortable with talking about it.
Yeah, you're so right, because, you know, it is really common, you know, but I think, you know, I don't really love the statement, but, you know, it's common, not normal. You know, just because something's common doesn't mean we have to accept it, and doesn't mean there aren't things that we can do. And again, like all things are driven by, you know, volume, aren't they? So the more people that are saying, I need help for this, means the more resources there will become, the more funding hopefully we'll get, you know, and I hope in another 5 years' time, you know, if I'm speaking to you again, we're talking about new and different things, and we've got even different data to support recovery from certain things. You know, all the time there's technology evolving, there's product evolving, you know, there's knowledge and understanding evolving. We're also getting much better at preventative healthcare. You know, we're recognizing the trends and things that we could have done earlier to try and prevent these changes. You know, even around abdominal separation, you know, years ago we said all sorts of things that, you know, if you look up blogs I've written 10 years ago, and probably saying, you know, after if you have an ab separation, you must roll onto your side, get out of bed, you know, don't ever do crunches and planks and things like that, because that was our understanding. And as our understanding and the research has evolved and women are demanding more and advocating, you know, we are learning more. And now we know that actually, you know, there's some fantastic researchers even looking at core exercise in pregnancy, and in continuing to do normal six-pack type of exercises, you know, not necessarily a crunch, although maybe, but, you know, actually using our abdominal wall and training it through pregnancy, and seeing correlations between that and certainly not any more ab separation in those individuals than women who are just scared to do anything with their core. And maybe we're even seeing an improvement. The same with pelvic girdle pain. You know, we used to say, well, you know, don't do X and Y. And now we're seeing that women who have got more abdominal strength are having less incidence of pelvic girdle pain in pregnancy. And so, you know, all of the people speaking out and reaching out drives interest, drives resources, drives research, and then hopefully means we have many more options. And the answer to the question earlier is then everyone can get back to doing what they want to do, you know, because that is ultimately what it needs.
Yeah. And just briefly before we sadly have to wrap it up, I'm curious to know You obviously see men come in as well.
Yeah.
We were talking off microphone before we started recording that you were saying that men just, you see far fewer of them, and there's like, they don't talk about it, and it's kind of even more of a taboo sort of topic.
Yeah.
Why do you think that is? And what sort of issues do men come to you with?
Yeah, and I think it's super interesting because we hear a lot now, or maybe I do in my echo chamber, around, you know, the discrepancies in female health and the lack of research and knowledge and awareness in women's health, which is 100% the case. You know, and you look at sport, for example, it's probably changed since I last read, but it's 6 to 7% of research in sport is done in women as a cohort, you know, so we know there's a massive lack there. But when it comes to pelvic health, I would say there's an even bigger lack in male pelvic health than there is in female pelvic health. And, you know, yet male, whilst they don't have the same risk factors in pregnancy and postpartum, and obviously not the same hormonal changes that women navigate, doesn't mean men are, you know, I can't think of the right word, but not going to suffer from pelvic health complaints. They can still suffer with constipation the same as women can, hemorrhoids, urinary incontinence, inability to empty their bladder. You know, men who struggle to initiate urinary flow can all be related to the pelvic floor, can also be related to other things. So all pelvic health physios will be very good at screening for something that's actually not a pelvic floor issue and needs to go and see someone different, like a urologist or a gynecologist or whatever. But men also have issues like erectile dysfunction, and again, you know, sometimes there's a pelvic floor component to that, an overactivity of the pelvic floor. Sometimes it's a cardiovascular, early cardiovascular risk sign.
Wow.
You know, so we're not getting sufficient blood flow into that area, and that might be a really early sign that someone needs to look at some lifestyle change. And actually, a lot of the data in erectile dysfunction looks at that. You know, at least 3 or 4 months of lifestyle change. You know, improving your diet, reducing your alcohol, improving your exercise, before we just go straight to the magic blue pill. You know, and often it is that early sign that someone might be at risk of a cardiovascular event like a heart attack or a stroke. And so if we can talk about that more, you know, as a preventative healthcare item, that's going to be super important, because rather than hiding that and taking a blue pill and, you know, masking it, if men are going and seeking the right support early, they may well put their whole health trajectory on a different path. So yeah, men will come in for all sorts of things, prostate issues like post-surgery, urinary incontinence, sexual dysfunction, bowel related issues, recurrent hernias as well, so kind of pressure control issues, pelvic pain. You know, we see cyclists with saddle anesthesia, so kind of issues in the groin area. So yeah, lots of different, same and different to women. So we still have the same bladder and bowel issues, but some, obviously, men don't suffer from pelvic organ prolapse in the same way.
The message, I guess, to take away is really just talk about it, and hopefully men and women will, in years to come, feel like it's something they can just go and have a checkup. You know, I guess even if you don't have the worst issues, but you're perhaps using the toilet more than you like, or, you know, to just have that check-in with someone like yourself to find out, you know, could I be doing better? Are there any exercises I could be doing to improve my situation? More messaging, more podcast episodes, and hopefully we'll all be taking a step in the right direction. For anyone who is interested in potentially speaking to you about potential concerns, where can you just tell everyone where to find you?
Yeah, so you can find me on socials, jennyfielding.physio, or at mint.women's health. So I work at a company called Mint, Mint Wellbeing. We're based in Wimbledon and also in Esher, and yeah, we have women's health and pelvic health physiotherapists that can see you there, as well as obviously normal physiotherapists and personal trainers and massage therapists and things like that. But yeah, I'm always happy to talk about it. I love doing educational work in schools and in corporates and things like that, and I'm also very happy to, you know, not being medical advice, but, you know, point people in the right direction towards resources if they're out of area.
Thank you so much, and it's been a pleasure. Yeah, I wish we could spend all day talking about this, because I had a load of
and such good questions.
Oh,
so well done.
Thank you. I had many more I didn't get round to, so hopefully one day we get you back on the show.
Fabulous.
Thank you.
Thank you.